Welcome all of you to this live program in Orthopedic Principles. Today our guest of honor is Dr. Abdullah Hachem from Barcelona, Spain. Dr. Hachem is Associate Professor of Orthopedic Surgery at the University of Barcelona in Spain. He's also the head of the shoulder unit of the Hospital Universitario Bellvitge and Tecnon Medical Center in Barcelona. Dr. Hachem is also Director of the Master Fellowship Program at the University of Barcelona. Dr. Hachem is a member of the Executive Committee of the Spanish Society of Shoulder and Elbow and is a past member of the Executive Committee of the Spanish Arthroscopy Society. He also chairs the very popular Barcelona International Arthro Shoulder Courses. Having exclusively practiced shoulder surgery for the last 10 years, he focused his research activities in the cutting-edge treatment of glenoid bone loss with free metal fixation systems. He is president of the upcoming Spanish Arthroscopy Association Congress in 2024. Dr. Hachem has multiple highly cited publications in the field of shoulder surgery and is a reviewer for the JSCS and the American Journal of Sports Medicine. So today it's my great honor to introduce you, Dr. Abdullah Hachem from Barcelona, Spain. Over to you, Dr. Hachem.
Good afternoon from Barcelona, and thank you, Hitich, for inviting me. You are doing a fabulous and fantastic and outstanding orthopedics website job. So again, today I'm going to speak about management of recurring posterior shoulder instability. Posterior shoulder instability, PSI, is an uncommon condition representing almost between 2 to 10% of patients with neural joint instability. And that this pathology affects almost 24 young active male patients treated surgically for shoulder instability. So if we take a look at the incidence, we have 6 times more male patients than females. And the incidence peak, we have 2 incidences of peak, with the mainly first one occurred between 14 and 19, and for both males and females. And the second incidence peak comes between the 3rd and 4th generations. This happened because sometimes the delayed or previously incorrect diagnosis of this pathology. So mainly this is because up to 80% and often during 25 years, we delayed this diagnosis. So this is happened because the clinical symptoms is wide and a variety of clinical presentations, from the pain, shoulder, and weaknesses, rather than instability, and the patient didn't refer as a clearly frank recurrent dislocation. Sometimes it's subluxations, and sometimes patients feel some demonstrable and non-voluntary episode. This is what I'm going to speak after that, about how we can distinguish between voluntary and non-voluntary. And also the misdiagnosis comes because they have a poor X-ray interpretation with the glenoid bone loss from the humeral side and the glenoid side. So the most important thing for this is to high clinical suspicion from the doctors to this pathology. So at the end, to understand what's happened, we should know the factor that predispose to PSI, mainly the hyperlaxity of the shoulder, local hyperlaxity, and we have a special functional muscle pattern imbalance between this anterior rotator and posterior external rotation of this muscle, the cuff. And we understand at this young and very young patients, the glenoid dysplasia take important roles because leads to anomalies in the development of the scapula, mainly in the posterior glenoid rim. As you can see, the 3 shapes described by Gerber, the pointed one, lazy J, or delta shape. And all of us, we know the standard classification with the 3 polar for each entity. So the PSI could be classified also in this 3 polar classification. And the main important for me is the 3rd polar, because this push to the question, something that what is the first, the chicken and the egg? Because if you can see this very young child, look at this, he is able to dislocate his shoulder inferiorly in the left side. At the same time, he can do in the right side, he will do it, look at this, but with a little bit posterior dislocation, because he does anterior flexion to produce the dislocation. But in the left side, he does it in the static and inferior dislocation. So maybe this young patient have functional muscle patterning imbalance that leads to a development and produce anomalies in the scapula. But we don't know if the scapula started, the anomaly started before this imbalance of muscle. So this is what I'm going to understand, the chicken or the egg. This is, we will never diagnose that. Look at this women. This is in the third age of look at she couldn't control the posterior shoulder dislocation. Look at here, and look at this dyskinesia or STAM. We can now speak about the STAM, scapular thoracic abnormal motion, with almost normal posterior veno drain. She didn't have any retroversion, but a little bit dysplasia in the posterior veno drain. So what we cannot be sure which happened first, the anomaly of posterior vein or the functional imbalance of the muscle. So look at this one. And sometimes the patient with a huge retroversion of the glenoid develop a hyperplasia and hypertrophy of the posterior glenoid that produce improvement in the retroversion from 25 or 30 degrees almost until 15. And the patient, only he wasn't able to elevate and abduct the shoulder without repositioning of the scapula, doing a retraction and external rotation. And here, look at this, he can only achieve this one by adapting his muscles and this position to this pathology. This patient, he referred to us without pain, only for this range of movement, anomaly of the movement, without any symptom of pain. All of us know the ABC classification, perfectly described by Philippe Moroda as the first episode, dynamic, static. All of this is you can put it all of this between subluxation, functional. I mean, we have all this imbalanced muscle and constitutional alteration of the anomalies in the bone can lead to this pathology. You remember the clinical presentation and structural lesion of posterior shoulder instability. In sometimes the initial small trauma and all repetitive micro trauma. In some time is the main direction of a multi-directional instability. Always, in some time, have a posterior capsulolateral lesion. And remember the reverse heel sac lesion, posterior groin defect. In patient, you should find the increased glenoid retroversion, posterior labrum hyperplasia, and at the end, smallest sample of patient have recurrent posterior subluxation. And most of this patient develop with the time the eccentric osteoarthritis in young patient. We call it a pre-B0 Walsh B concavity in the future. This is truly important to thinking about this patient, high suspicion with this patient to find out this pathology. So after the high clinical suspicion, we should find also how we can detect this demonstrable posterior instability and the volumentarity. We can do all the tests described in the literature with jet test, skin test, load and chief, and this is mandatory in this type of pathology to have X-ray, CT scan, and MRI to discover, to see what's happened in the posterior glenoid, what's happened in the bone and the version, the posterior dysplasia, labral lesion, all of this. This is very important to reach out that. So I'm going to go to show you now some patient. Look at this. This is in the left side. He is able to reduce the posterior dislocation in non-functional position. This is non-functional because the arm is close to the body. In the left slide, your the right side, the patient, to dislocate his shoulder, he put the arm in the upper side as kin test position. Look at this, and he is able to reproduce and demonstrate this non-voluntarity of positional dislocation as this patient. This is the first thing we should do. Is it functional position or non-functional position? This is another thing. We should detect the hypermobility. Look at this. This young patient is very hypermobile, and he can reproduce the posterior shoulder dislocation with voluntarity, demonstrated voluntarity, but not volitive. I mean, not he didn't have any psychosis but he in the beginning he feel like he not comfortable with this position, and he tried to do it to avoid the pain, the future pain. This patient at the end he presented adrenal dysplasia. Look at the CT scan and look at the retroversion and the posterior anomaly of the posterior glenoid. We should understand to detect all this pathology. We should do a CT scan. It is mainly CT scan. We know now from publication the gamma angle to find out the degree between the most deeper zone of the occipital groove and the most posterior side of the glenoid defect, humeral defect. So this is, we call it gamma angle between the reverse heel sac, the posterior border of the reverse heel sac, and the occipital groove. This is gamma angle, and the delta angle is from this line posterior to the reverse heel sac region and the posterior glenoid rim. And always when we have a good correlation between the posterior defect and this degree of the delta angle. We have association between the gamma angle and delta angle and the engaging heel sac lesion, reverse heel sac lesion. That means, this is published by many authors, when this gamma angle is less than 90 degrees, we don't have an engaging heel sac lesion. But if this gamma angle is more than 90, we will have an engaging reverse heel sac lesion. And this, and more important for me, is this work published by Mike Provencher and his team, because they study 75 cases with 19 failure. And in 6 cases, the failure was with a glenoid defect, posterior glenoid defect, more than 11%, and in 1 case, more than 15. So they did a linear regression analysis, and the conclusion was, when you have a posterior glenoid bone loss, if this it is between 11 and 15, you will have 10 times a high failure rate with capsular repair. Only with soft repair, you will fail. And if your posterior defect is a little bit more than 15%, maybe we will have a 25% higher failure rate regarding to this soft procedure. So this is most important thing to understand, that there are no treatment consensus, because we have a lot of techniques, a wide variety of soft tissue-based procedure or bone-based procedure. And we have almost, we have big database and resulting in a high failure rate with soft procedure, soft arthroscopy procedure. So maybe we need details studies to be need, and we randomize control trial, but it's impossible because it's a very, very uncommon pathology. So we published our experience with ill experience. Was almost now we have 11 patients. We started with doing 4 screws, and after that now we have 10 with cerclages without metal, and we published our proposal algorithm. In this proposal algorithm for symptomatic recurrent posterior instability, structural or functional. Always we started with physical therapies, always. And if the physical therapy for at least 6 months failed with persistence of symptoms, mainly pain, we could find the posterior dislocation with a patient with a multidirectional or unidirectional. If the patient could demonstrate this posterior instability, but without voluntarity, we could do a surgery. But if the patient have an intention to win with voluntarity, never we should do the surgery. For me, it's prohibited. So in mainly when we have a clear defect with less than 10% in this unidirectional or multidirectional with demonstrable or non-voluntary, we could do. In these cases with less than 10%, we look at the gamma angle. Is the gamma angle is less than 90 with less than the smallest defect, we could do capsule application, not only repair, capsule application, posterior capsule application. If the defect is less than 10% with a gamma angle more than 90, we should do capsule application plus reverse heel sac remplissage. So in cases with more than 10% of the green defect and retroversion more between 10 and 25% or green dysplasia in posterior glenoid, we should do. My indication is posterior bone block cerclage without metal. In some cases, with a failed from the beginning, with a failed capsulabral repair soft tissue procedure, we could do a bone block procedure also. And in some cases, without defect, a green defect in demonstrable and non-voluntary, we could do from the beginning bone block, posterior bone block as an augmentation to augment this glenoid tract to avoid this dislocation, heavy dislocation. So I'm going to share you now some examples. This is typically no posterior glenoid dysplasia, no posterior defect. I perfectly described here detachment of the posterior capsulabral complex from the 11 o'clock until 6 o'clock. I always, lastly, I started to use knotless system with a suture and anchor, I mean with PIC or with bioscrew. And now we are going to soft tissue implants as FiberTac. All the companies have this kind of implant. In this case, the lesion involves the posterior biceps. This is a slab type 8. At the end we put 304 anchor as this system is impacted system, knotless system. This is final view for this posterior shoulder instability repair. So in some cases we have, as I said, a gamma angle with more than 90 degree and the glenoid bone loss less than 10%. We described and published this technique. This is a reverse heel sac remplissage. This is a reverse heel sac. We introduced the first anchor through the subscapularis with a tape, and the second anchor comes above the tendon subscapularis, like a hug. The first is through the subscap, the second one is above the subscap. You can see this in open arthroscopic technique, is open and not locked. This is a final view without any screws, any knot, without any knot, only screws and tapes with a wide compression of the foot frame with these tapes. So also now we describe, all of us see the bone block cerclage as this is indication. As I mentioned before, I repeat here, bone block indication for me when a defect is more than 10%, posterior glenoid dysplasia, a retroversion between 10 and less than 25. You can do it in demonstrable, non-voluntary cases and in failed posterior labral repair. So look at this. This is a case I did it in more than 4 years ago. This is a guy who presented before. Look at this. I put 2 anchors with a glenoid bone loss here, glenoid bone defect here, presented, and dysplasia. I put this bone block, but always the patients suffered intolerance to these screws. We have now publications with a minimum follow-up more than 5 years, and we know the arthroscopic posterior bone block is doing reliable and efficient with a good long-term result. But we know from the literature the screw removal almost is 30%. In my case, in my own experience, from 3 patients, I needed to remove almost two out of 3. This is 66%. So because the graft in the posterior glenoid rim suffered always a resorption, remodeling, and at the end, the head of the screw comes out and provoke an irritation of the soft tissue, mainly in infraspinatus, the same as lateral in the anterior glenoid side. Look at this. This is we did this patient. At the end, I removed this patient. He improved a lot after removing this screw under arthroscopy vision directly, and the patient improved a lot, and the symptoms came from the patient and came out and improved a lot. In this case, I couldn't remove. I only could remove the head of the screw, and I cut the screw because it was integrated, very integrated. I couldn't remove the core of the screw in the scapula. So for posterior bone block cerclage, you should know the tapes, 4 tapes, goes through the graft and through the 2 tunnels in the glenoid, and again from anterior, the tapes goes again to posterior. At the end, we interconnect this tape. I'm going to show you this case. This case presented a gamma angle less than 90, retroversion 13, and glenoid bone loss more than 10%. He presented all these functional scores with bad results and raw scores, SSV, WASH score. He presented this defect. We do this technique in lateral decubitus position. The scope always in ACISL portal. In some time, our posterior portal is too high. As you can see here, we should do another portal, posterior inferior, to goes through the posterior inferior rim. And here you can see that the lesion of the posterior capsulolabral complex, we should detach the labrum at 11 o'clock to keep far away this capsulolabral complex, far away, as we do in the anterior glenoid defect. And to do this one, we introduce percutaneously the suture lasso. This is the Pascal Boileau technique to keep away far away the capsulolabral complex using a PDS suture. We debride always the posterior glenoid rim, and we measure the defect length to adapt our graft to the posterior glenoid rim. In some time, we should do a minimal bone debridement to put it flush and smooth to adapt the graft. We split the infraspinatus muscle by helping with this scissor. The new guide designed for posterior glenoid with the company came from posterior with a safety angle and with two steps of offset, 5 and 7 millimeter. We drill from posterior to anterior, 2.4 millimeter. You can do it with 3 millimeter. Now we shuttle the nitinol wire from posterior to anterior. This is a technique animation for anterior bone loss, but the same for posterior, but in the opposite way. We retrieve from rotator intervals 2 nitinol wire with a cannula anterior, and sometimes the second tunnel is a little bit distal to the superior one. Then behind the subscap, we should cut a little bit the capsule to find the exit point of the drill. Now we exchange this 2 nitinol wire with 2 fiber link to avoid the breakages of the nitinol. We should always measure the distance between the cartilage to the exit point and the entry point of the tunnel to adapt the glenoid, the bone to the posterior rim. Now we use a syringe to facilitate the introduction of the graft. This is a new generation of the tapes. Comes from the company. The tapes fly from posterior. The graft is in opposite way. Is not as you can see here. This is a for anterior one. The graft comes directly from the posterior one, and this is here the bridge of the tape is the anterior one. And now this is a posterior side of the patient, the interconnected of the tapes, and now we introduce by helping the sealing the graft. And then we use always the graft sitting. It almost goes in front of the posterior wall of the glenoid. We use a tensioner, and sometimes I prefer always to be a graft a little bit proud. We can remake a little bit 1 millimeter to achieve a new concavity. And then we reattach the capsular complex with a soft anchor to keep the graft outside the joint. This is a result 3 weeks after the surgery. Look at shape of the graft is the posterior inferior glenoid is almost this is augmentation of the glenoid with a good shape of the glenoid. So now look at this. This is a graft 12 months after the surgery. After the surgery, 12 months, he could do now can demonstrate the instability. And now look at this, another patient, 2.5 years post-operative, and the shape of the graft and the after remodeling, the shape of the glenoid is perfect, almost perfect, using allograft because we put with high compression of this graft. And now at the end, I'm going to share with you what's happened when you have a retroversion more than 25%. In this particular cases, this is excessive congenital glenoid retroversion. The opening wedge osteotomy has been proposed by many publications, by several authors, to reduce the high failure rate after soft anchor. And this particular cases, if you put an augmentation or bone block, it's a little bit still have. We can do it, but we should put it. I mean, as a step, it maybe provoke a little bit augmentation to arthritis. So we have now limited studies about assessing this proposals of osteotomy. We are going to publish our arthroscopic posterior open wedge osteotomy. We did it. This is a feasible technique. We're going to publish in the arthroscopic technique. This is the same guide for posterior bone block. It's introduced from posterior. We put 2 key wire a little bit parallel to the glenoid surface. It's the same. We detach the capsule, and now with a specific devices, and osteotome comes from posterior, which is graduated. We could do only 15 to 20 because you remember the diameter by a radius of the glenoid is 25. So in the beginning we go to inferior side and the middle side, and after that we change the direction to posterior. All is very safety because we are always under control all the cartilage. At the end, we could introduce both two osteotomes, as you can see in this image, and the graft. And sometimes we could have the graft from the iliac crest or from posterior spine scapula. We need the smallest graft. The graft is introduced between both osteotomes. We have specific device. It is auto-stable graft with a osteotomy. And at the end, we push it, we impact it, and we don't need any fixation. But only now we did it with a soft anchor after reattaching the posterior glenoid rim. So soft anchor goes to the graft and to the native glenoid rim to have a good unstable osteotomy. At the end, in summary, I will conclude for recurrent symptomatic posterior shoulder instability. The most important things is to high clinical suspicion from the doctors, and to do a good clinical exam to find out, to discover the hyperlaxity. Some patients have only a local hyperlaxity of the shoulder without general hyperlaxity. I mean, we now have data from no correlation between the Bateman scores and local hyperlaxity. And we should define the voluntarity and demonstrable posterior shoulder instability or not. And for this particular disease, we should do both CT scan and MRI to discover if we have hyperplasia or hypertrophy of the posterior glenoid rim. And soft tissue procedure, if we follow an algorithm, standard without glenoid defect, it works. And glenoid bone block without metal, this is my indication, my preferred technique to avoid metal scoop related complication. And then in the future, we hope we will have some clinical data to be sure the posterior arthroscopic posterior open wedge osteotomy would be less harmful to the patient than the open osteotomy. At the end, I will, if you permit me, I will invite you. I hope all of you can come to Barcelona in the last of November and the 1st December. We'll have 16 live surgeries. and real-life surgeries with round-table discussion, clinical exam with Bassem and Derek for the troubles around the scapula. All this panel comes from Europe and from the United States. I hope you will have and we will join us in last of this year. Thank you. Thank you for your attention. Thank you, Dr. Hitesh.
Thank you, Dr. Hachem, for this amazing presentation. Dr. Hachem, you can stop sharing.
Yes, just a minute. I try to stop sharing here. Yes, perfect.
Thank you, Dr. Hachem, for this excellent presentation. A lot of new insight into posterior shoulder instability.
Thank you.
And few questions, Dr. Hachem. Now, Dr. Hachem, what do you think are the differences in surgeries between anterior and posterior shoulder instability? For example, in this anterior side, you have capsulo-labral plication, you have capsular shift, and we even have it remplissage on the posterior side, right? So what are the other differences? For example, I saw that there is glenoid osteotomy is one thing that you do on the posterior side. What are the other differences when you compare it with the anterior side?
The most important thing for me is the clinical exam, because posterior shoulder, recurrent posterior shoulder instability is more common, and I mean the frontality or this demonstrable more common than anterior one. This is the first one. The second one, we have more dysplasia and anomalies in the posterior dream than the anterior one. Anterior one, only we have a clear defect, only defect. But in posterior ring, we have a sequel of OBPI, a little bit smallest symptoms. I mean, it's not a true neurological lesion. And we have, this leads to, from the beginning, leads to anomalies in the posterior ring, leads to imbalance of the muscles. So all of this kind of pathology, we don't have it with high frequency in the anterior side. Anterior side is very, very true, and we have wide clinical data how we manage the anterior glial dream. Posterior glial dream is a little bit, for me, is more important to listen to the patient, examine the patient, find the hyperlaxity, more important to find out the most important direction. Is it inferior? It's mainly posterior, and listen to the patient. Ask the patient to how could you provoke this? Could you demonstrate this one? At the end, when the patient have some psychosis, you can detect it. It's very simple, because one patient came to me and he said, "Doctor, I want from you to prevent me. Look at me." He provoked the instability and he started to beat himself because he was very anxious. So this kind of patients this is a voluntarity, but a little bit a neurosis, a psychosis. I send him to the psychiatric and psychology to treat this pathology. So this is most important changes and differences between posterior side and inferior side, anterior side.
Thank you, Dr. Hachem. And Dr. Hachem, we commonly describe about the sulcus sign, right? We do when you do an inferior movement of the arm, there's always a demonstrable gap just between the acromion and the shoulder. So do you think what is the relevance of the sulcus sign? Is it a part of an NDI or is it a part of posterior instability? Of course, it is inferior. So what is the clinical relevance of it?
This is a truly difficult problem, because if you have, I mean, I never seen a bidirectional instability. I mean, always anterior inferior or posterior inferior, but we have some patients with the static inferior instability. This patient with, I mean, always if you have an anterior instability and you find a sulcus, go to the axilla, shift the axilla. Don't worry. Go detach all the capsule until 7 o'clock. Bring 7 o'clock to 4 or 5 o'clock. Don't worry about it, because this is most important cause to fail in the anterior glial dream. In the posterior, it's different. I explained the management. So, but I received some patients, a failed patient with anterior stability. At the end, if you examine the patient, they only have 40-degree or 30 degree of external rotation with the arm at the side. But when we do when we do this sulcus test, we have a huge sulcus test, more than 3+. So that means the inferior pouch is very lax. And if the patient lose the control of this stability, it's very, very dangerous to control it. Some patients in my hand finished in scapular arthrodesis of medial joint. So now we have see a publication from Matthias Zamstein from Bern. He described a new reconstruction of these two hammock with two bands of anterior and posterior IGHL band with a tunnel in the uterus. Is a good technique to this particularly kind of patient with static inferior dislocation. So I've never seen, as described by Nir in the beginning, bilateral dislocation, symptomatic bilateral dislocation. Maybe we have hypermobility. This is true. Anterior, posterior, and anesthesia also you can confirm. But the patient comes to us to dislocate the shoulder anteriorly. I found also some sequel of tying too much anteriorly, and patient started with a posterior stability. I mean, if you should balance your shoulder, the balance for me is always in the axilla, not only anterior and posterior. Only go to the axilla. This patient with hypermobility, go to the axilla, shift the posterior band, shift anterior band from inferior to superior. This is the most important thing for me. I mean, it's very difficult, but in these cases, yeah, we are going to try the Samson technique, Matthias Zamstein from Bern, to reconstruct these two bands of inferior IGHL.
Okay, thank you, Dr. Hachem. Dr. Hachem, one last question before we end the session. Now, Dr. Hachem, you're a big fan of a metal-free cerclage, right? Because that is the previous talk. I mean, on the anterior side, you do that. I mean, you're very happy with that. Do you think you will get these similar results from the posterior side?
Now, a good question. Good question. The most important thing is I'm trying to write to send the paper about what's happened in the remodeling and osteolysis and the reception with the graft. So we found if you put every single graft, if your graft is bigger than the best fit circle, always under the wall flow, your graft will disappear. At the end, the result is perfect. The shape, the remain shape is the glenoid side. So having said that, I mean, it doesn't matter. Your graft should be always bigger than the best fit circle. For me, why? Because if you put it bigger than best fit circle from anterior or posterior, you are sure and accurate to cover all this best fit circle. If your graft, when you use a collaborative process with maybe 20 or 25% of the defect, your graft, you should worry about, I put my graft lower, I put my graft higher, I put my graft, smallest graft and can't feel all the best fit circle. So with these cerclages, we found high union rate, almost 100%. But the behavior is a little bit much more in the posterior than anterior. Why? Because always our indication for renal bone loss is less than anterior. For anterior is more than 15. In the posterior side is 10%. So I put my graft, the graft is three times much more bigger than the defect. So the final result, if you ask me, how is percentage of the resorption in the posterior side? I will see 60%. 60% because my graft is bigger than the defect. In the anterior side, no, it's less, 30%. So this is what happened, the behavior between both sides, the differences.
Thank you, Dr. Hachem. Dr. Hachem, I think that's all the questions that we have for the session. Thank you for yet another brilliant presentation. And we really look forward for the Barcelona International Showcase.
It's my pleasure. And thank you very much. You are doing a great job with this orthopedic principle. Congratulations and thank you again.
Bye-bye.
Bye-bye.